Hi, my name is Evelyn. This is my central lines and art lines video checkoff. So first thing I'm going to do is check off my anesthesia machine. I'll come in the room, make sure it's hooked up to power. I'll check my gas pressures. So nitrous for my tank will be above 745, and then oxygen should be above 1,000, and then my piped pressure should be above 50, actually around 50. And then I'll check my vaporizers. I'll make sure these caps are secured on tightly. I'll make sure they're full of the liquid. I'll make sure I'll do my interlock system check. I'll do my link 25 check, and then I'll do my low pressure system leak test. That will pass, and then I'll turn my machine on. I can check my O2 analyzer, my CO2 absorber, and my scavenging system. Check my monitors, my equipment, that I have everything. Then I'll do a high pressure system check. So I'll close my APF valve all the way, O2 flush until this reaches 30, and then it should hold for 10 seconds, and that means that it passes. So once I've done my machine check off, I can move on to things that I'll need for the case. So some of my V drugs that I need are midazolam pre-op 2 milligrams for this patient. We're just doing an adult male. Fentanyl 50 to 100 mics per kilogram, lidocaine 1 to 1.5 milligrams per kilogram to blunt the sympathetic surge of intubation. Propofol 1 to 2 milligrams per kilogram, rocuronium 0.6 to 1.2 milligrams per kilogram, and then SIBO for maintenance during the case, around 2%, and then Zofran for emergence 4 to 8 milligrams. And then some of my emergency drugs that I'll have backup are atropine 0.4 to 0.6 milligrams, succinylcholine 1 to 1.5 milligrams per kilogram, epinephrine 1 mic per kilogram, phenylephrine 0.5 to 2 micrograms per kilogram, and then ephedrine 5 to 10 milligrams IV bolus for a max of 25 milligrams. And these are just for blood pressure control during this specific case. Other things for intubation I'll need is a MAC blade, which is size 3 to 4 for an adult, and then a Miller as backup, just in case the MAC gives me trouble or they have weird anatomy. So Miller 2 to 3, and then lastly a gyroscope, just in case they're a really hard intubation that I just don't know why. And then ET size is I'll have an 8.0 likely for a man, but I'll have it half size up and half size down. And then I'll have a stylet also, and then some lubrication jelly for these. And then also I'll probably end up securing 22 to 24 centimeters at the lip. And I'll have an oral airway, a mask, an ambu bag, other airway items. And then lastly, I'll need my central line kit for this specific procedure, and then an art line kit, and then gown, gloves, drapes, etc. to put those in. So now that I've set up my room, I can go back to pre-op and pre-op my patient. So I'll identify the patient, say hello. This patient is a 40-year-old male. They're 75 kilograms and they're an ASA of 1. The procedure that we're doing is an elective robotic assisted laparoscopic prostatectomy, and I'll just go over some medical history with them. I'll go over some medications, malignant hypothermia, allergies, NPO status, if they've had issues in the past. I'll do a physical assessment. I'll have to listen to heart and lung sounds, just review their airway, do a Mullen potty. Then I'll discuss the plan, risks and benefits and alternatives of the case and these specific lines that we need for the case. So for our plan, I'll just say we'll be placing 2 lines. There's gonna be one in your neck, there's gonna be one in your wrist. These are gonna help us monitor your blood pressure and help us give you medication safely during surgery. And then risks, there's a small risk of bleeding, hematoma, infection, or accidental injury to nearby structures that we poke these lines into, like arteries or nerves. For the next line specifically, there's a rare risk of lung injury, but just so you're aware. And then benefits of these lines, having them, is that they let us monitor your blood pressure beat by beat and give you fluids very quickly and accurately, especially during longer cases like this one that are complex. Alternatives is for some surgeries, regular IVs and blood pressure cuff are enough, but for this specific procedure, we're gonna need a little bit more invasive control of your blood pressure to keep you the safest. So once we go over that, then I'll obtain proper consent for the IJ, the art line, and the surgery for anesthesia, and then I'll push some midazolam and wheel them back to the OR. So once they're laying down in the bed in the OR, we are just going to mask them with some oxygen to pre-oxygenate and denitrogenate 6 to 8 liters per minute total, roughly. And this should cover the bridge of their nose and encircle their whole face. That should have a proper seal. You want it to just be sealed the whole time you have oxygen. They should be aligning their airways in sniffing position. You can tell adults to just breathe deeply because they know what's going on. So for my IV induction, once it's been a couple minutes and I feel like they're properly pre-oxygenated and denitrogenated, I can use fentanyl, lidocaine, and propofol that I prepped at the beginning, and I can intubate once the patient is fully asleep and in stage 3, and I'll just test their lid reflexes and how relaxed they are. So I'll intubate, I'll get my blade, that'll be a really easy intubation. I'll put my ET tube through the vocal cords. I'll just visualize that. They're going through the vocal cords, misting, I'll ET CO2, chest rise. I want to see tidal volumes, I want to just listen, and then I can secure the tube to the patient once they're finally in a good spot with that tube. So now, once the tube is secured, I can hook up my circuit back to SIBO and then give maintenance rocuronium for the case, and then I can reduce my O2 to 2 liters because I'm using SIBO, and they're pretty much ready and asleep for the case. So now, since they're asleep, I don't need to consider sedation for putting in the central line, so I will skip that part. So central line IJ placement, I can start this procedure. I'll just position the patient supine. I can make them slightly Trendelenburg. I can turn the head away. And then I want to make sure I have these specific landmarks. So I have the sternocleidomastoid muscle. I have the 2 heads, the clavicular and the sternal head. I want to identify the clavicle, the carotid artery. I want to feel that and make sure I know exactly where that is. And then the ipsilateral nipple just for placement. So now I can sterilely prep them. So I'll scrub for 30 seconds and let that dry. And then while that is drying, I can open my kit. And once my kit's open, then I can sterilely gown up and drape. And I'll pull my drape out of my gown, out of my kit, because I'm sterile. So now I'm sterile. I'm gonna drape my patient. So now my patient's draped and I can continue prepping my kit. So I'll just flush all the ports with NS and then organize this in a way that I like it. So now I'm gonna get my lidocaine prepped for the skin incision. And anytime I have a needle in the patient, I am going to palpate the carotid artery so that I don't accidentally stick that. So palpate the carotid artery, and then I'm going to just numb the surface of the skin with about 3 cc's of lidocaine and a 27 gauge needle. So once that is done, I'm done with this lidocaine. Now I'll get my finder needle, palpate the carotid again, and then I'll insert the finder needle at a 30 to 45 degree angle while I'm aspirating until I get dark blood aspirated. So now I'm confident that I'm in the IJ because I got aspiration. I can take off the syringe for more room, and then I can hook up my actual needle and insert it parallel to the finder needle while I'm aspirating. So I'll palpate the carotid artery again, and then insert this needle parallel to my finder while aspirating, and then I will get blood return that's dark. So now that I have gotten blood return, I can take out my finder needle, put it in my sharps. I can take off my syringe. There's going to be dark red blood kind of dripping back, and that will also confirm that it's not pulsatile and I'm in the artery. So now I remove the syringe and I can get my guide wire out. And so now I can advance my guide wire through my needle, and I can watch for, on their monitors, watching for ectopy this whole time to kind of confirm how deep my wire is. So now my wire is in the right place, and I just want to make sure I control my wire this whole time. And now I'll take out this needle with my wire still in place. And I will puncture the skin site with a blade, with the blade facing the ceiling so I don't shear the wire accidentally. So I'll puncture the skin site and then advance my dilator over the wire. Bury the dilator, bring the dilator back out, controlling my wire the whole time. Now I'm removing my dilator, and I can place my flushed central line over the wire, making sure that it comes out of the brown port if I have a multi-port central line. This is a single. And the proper depth that I should secure my central line is specifically in the right AJ, it should be around 16 centimeters, but it's the patient's height divided by 10 if you need to calculate it. So once this is placed at the correct height in the patient, I can remove my guide wire. And I can aspirate my central line, make sure it's in the right spot, and then I flush with an S just to make sure it doesn't come out clogged. Then I'll suture my central line in place with a braided suture with about 3 knots, and then place a dressing over it, and then order a chest x-ray to confirm the placement before use. But during this time, I'll kind of monitor the vital signs every 5 minutes for the next 15 minutes to make sure the patient tolerated the procedure well, and then I'll chart this. So once I know this, now I can move on to my arterial line. And we already talked about consent with the patient when they were awake, so I don't need to do this at this time. We talked about risks, benefits, all that stuff. So patient's sedated. I'm just gonna have their arm on an arm board. I'm gonna do an Allen test. I'm gonna check for flow, make sure they can tolerate in art line. So they pass, the arm will be extended on a board, the wrist will be dorsiflexed. I can tape their thumb down and just make sure their hand is really exposing the art line, or the arterial vessel that I need to stick. And then I can set up my pressure bag, my tubing, to make sure I can quickly set this up so the patient doesn't just keep bleeding out. And then once I have all of that in my kit, then I can prep the skin with ChloroPrep, so I'm letting that dry. And then I can get my Artline kit and my sterile gloves. I'll open that and then don my sterile gloves, drape my Artline if I need extra space or absorption. And then I can take some local, and then I can localize the area for pain management with a 30 gauge needle, similar to the central line. And then I can nick the skin with the bevel of an 18 gauge needle to help the Artline catheter go in easier and not fold on itself. And then I just take my Artline, I open this, and I'm going to use the pencil technique, and I'm going to insert 30 degrees to the skin, and I'm not going to do through and through or any other technique at this time. I'm just demonstrating this. So I'm going to palpate the radial artery and insert my catheter and needle, and then I'll get flash of blood once I'm in the right spot. And the wire should freely advance at this point, so I'll advance my wire all the way. My catheter should just walk right off of that. I can discard these needles and catheter. I should just pull that out as the same unit so I don't shear the line. And then there's a risk of dirty sticks with these specific Keith needles. And once I have discarded of that, I can hook my tubing up and just check for waveform and blood return and make sure it's in the right spot. And then I'll suture it if I feel like I need to do that, and I can secure it with an occlusive dressing and just make sure it's ready to go. And then I've just done my central line and art line. Thank you.